Assalamualaikum and very good morning. For this morning, we're going to discuss about the realm of BPPV or the world of BPPV. And there are three main topics I would like to go through: is overview, algorithm of BPPV, and issues in BPPV. Issues meaning that the problem or the thing that we encounter when we're dealing with patient with BPPV. BPPV is a benign paroxysmal positional vertigo. It's benign. Paroxysmal is sudden onset and very dramatic. Okay? And we can, from our experience, that when we see a patient with BPPV, the way they describe the BPPV is not the same as other positional vertigo. It's a bit dramatic. And it's a clinical disorder characterized by two things here: brief episode of vertigo, very brief, less than 1 minute, and precipitate by changes in the head movement. And that's the thing. And then when the patient will give history that when they move the head and they experience the spinning sensation, as compared those in the case of what we say positional vertigo, then they move a bit, then the symptom go away almost immediately. That's when people ask us what's the difference between BPPV and positional vertigo. There is the BPPV, when they move the head, the symptom linger a bit more as compared to the positional vertigo. BPPV is most frequent vestibular disorder seen in the clinic, so therefore it's most important, because we will see this BPPV when we're dealing with patient with a floating or sensation of vertigo patient. Or as an ENT, we will see BPPV, definitely we will see BPPV in our clinic. And the good thing about this is there'll be a spontaneous emission after days or week. However, although it's a self-limiting, they will affect the daily activities of the patient, affect their work. They cannot go to work, and that's why they come to us. And plus, it's very troublesome. They cannot go, even they cannot take care of themselves. Sometimes they have to kind of bedridden. They can move. There will be vomiting. There will be a linger sensation of floating or imbalance. And whatever we do, there will be a recurrence, about 50%. Out of 100 patients, 50 will be a recurrence. Will come back to us. And some of the papers say that we do different manuals. We do different manuals as compared to other manuals. The recurrence will be less. It's open for discussion. In textbook, and we read the textbook, the most common occurrence is a posterior BPPV, up to 95%, meaning that out of 10 patients of BPPV, 9 is a posterior. Second, followed by horizontal canal BPPV, is up maybe 10 from up to 15%. And the least common is anterior canal BPPV. And some author even don't believe the existence of anterior canal BPPV. We come back to that. And etiology, 50% we don't know, idiopathic. And if we do read the books, and we can see at least 5 to 10 possible causes of BPPV. And logically, when there's so many causes of BPPV, actually we do not know what the real cause of BPPV. And however, in the young patient is associated with the head trauma, especially in the motor vehicle accidents. Other than that, in the old age, which is common to occur in the old age, we're not very sure why the old age, more than 55 years old, they have more incidence of BPPV as compared to the younger age. Still, we're not really sure about that. However, BPPV patient, we found out it's more osteopenic or osteoporosis, and with recurrent BPPV, those who have patients who have recurrent BPPV have a lowest bone density scores, and we come back later on with this information. And this suggests that during this autocorneal release, there are some process of bone demineralization occurred. Pathogenesis, there are two things. There are two pathogenesis that are being discussed, canalithiasis and cupulolithiasis. Canalithiasis meaning the stone is in the canal of semicircular canal. Cupulolithiasis is meaning there's a stone on the cupula of the semicircular canal. So semicircular canal, they have ampullaris there, and inside the ampulla there is a cupula. A cupula is a gel-like sustain, and then when the otolith start to the cupula, we call it cupulolithiasis. And this is the diagram, the picture of canalithiasis. We can see this is vestibule. Vestibule, inside this vestibule, there's a more, the nearest is utricle and away a bit on a sacule. And as we know, utricle and sacule, there's a stone, there's autoconia on top of it, and somehow they been released and they travel, and by gravity, when we sleep at night or we have we bend our head, they go into this canal. They go into this canal, and then if they stay here, it become a called canalithiasis. Sometimes the stone travel inside the canal and they start to the anterior arm or start to the cupula head. We call cupulolithiasis. And in the canalithiasis, the stone float freely in the canal. See here, they can be here or can be there. However, they cannot come out from there. They have to come out the way they come from. That's the basis of the mandible later on. And because of this otolith, and this otolith, they have they have weight, and when they enter this area, this endolin, the specific gravity of this endolin is slightly different as compared to other canal, the other side. I can say if this left side on the right side, they'll be different in terms of specific gravity, and this alone cause some feeling of imbalance. And when they move the head, the endolin that have the otolith inside there become more thickened, more dense, and more heavy. So the cupula also respond more sensitive as compared to other side, which it doesn't have this otolith, and that's cause the feeling sensation. If the otolith is heavy enough, they can cause a bending of hair cells. There will be a nystagmus there. Okay, and again, this is when the otolith attached to cupula, we call cupulolithiasis. And as we can see, canalithiasis is the otolith is floating freely in the canal as compared on the cupula. Stuck to the cupula, cupulolithiasis stuck to the cupula. So we can postulate here is easier to handle the canalithiasis as compared to cupula, because it's stuck to cupula. It's not easy to the cupula, because the cupula is sticky. It's not easy for the otolith to just simply come out into the canal. And again, it's the same. When the cupula is when the otolith attached to the cupula become more sensitive. We are comparing this one side of a cupula to the other side of cupula who doesn't have an otolith. So the one that have otolith more, they are more sensitive as that one who doesn't have it. Then so there will be a mismatch of firing of the hair cell firing or the sensation there. So patient will feel, the very least patient will feel imbalance or giddiness or dizziness. And if the otolith is heavy enough, there will be a nystagmus, will be a full-blown BPPV. So how we diagnose the BPPV? Diagnosis is from the history and from the office examination. From the history, what we're looking for is the history of spinning sensation, vertigo. Patient will come to us, say, "Doctor, I wake up this morning and I see the whole thing move, my whole room move, spin, or myself spin, and it's a very short duration, but however the floating sensation linger for the whole day." There's two things there: spinning sensation and floating sensation. The spinning usually is a short while, only a brief duration, but the floating sensation, they linger for a few days. That's already traveling troublesome there. And we should ask then, what you mean by, is it when you say giddy, you say pening, or you say, when patient come to us, it says giddy, pening, or headache, what you mean by that? Is it spinning? And we say, is it spinning? Is it, how long is it spinning? They say short while. Then is it followed by floating sensation? Just like you feel you are floating, drifting, just like in the boat. That's very important, because those patients who give a history of spinning followed by floating, almost always a BPPV. Almost always a BPPV. As compared to those who complain of floating alone without spinning, it still can be a BPPV, but we need to rule out the medical problem, the medical cause of the floating sensation. Most common is a hyperviscosity syndrome, right? And the phonetics itself, that doctor, whatever I move the head, I bend down, I turn to the left, to the right, I hang my clothing, I'm doing the cooking, I'm working on the computer, so whatever the movement of the head, I'm doing gardening, that induce or precipitate the spinning sensation. That's very very important, very significant in terms of diagnosis of we thinking of working diagnosis as a BPPV. And it's a brief duration, just like I said. And because BPPV, because otolith things, and they move when when the patient move, the otolith take times to move. That's why there's some brief latency there. Then after some time, the otolith settle down on the floor of the semicircular. There's no more there, as compared to the other thing, as in the case of vestibular, when the problem is inflamed of the nerve inflamed, so the sensation will linger more longer as compared to the otolith issue, as compared to the brain issue, cerebral issues. That's why there's a visit there. To complete the diagnosis, is the best we can identify which canal effect. Is it anterior? Is it posterior? Is it a lateral? And it's good as well if we know, is it canalithiasis? Is it cupulolithiasis? Although in this aspect is not as easy as to the first one to specify which affected canals involved. I'm quoting document of the Committee of the Classification of Vestibular Disorder of the Veronese Society, and this society is a group of people who have a special interest in vestibular disorder, and they come together and they come up with this statement. So how we then gonna diagnose BPPV? This is according to theirs, and let's see. Let's go through how they put up the criteria to diagnose BPPV. First, if you see there are posterior BPPV, there are horizontal, there are probable BPPV and anterior BPPV. And most of the BPPV here is canalithiasis. Only one in horizontal is a cupulolithiasis. First, canalithiasis of posterior BPPV. First, the patient should have to give a history of recurrent attack of positional vertigo, or any history of the giddiness feeling provoked or precipitated by the head movement, and the attack should be less than 1 minute. And usually there'll be the number C, there'll be a latency before we can see the nystagmus. And in this case, they use a disopite maneuver or small diagnostic maneuver, side-lying maneuver. Sometimes side-lying maneuver we call modified disopite, and it's more or less the same procedure. And most important here, to see the nystagmus. How we see the nystagmus? So imagine this is the eye, and we see the upper pole of the eye. And when it moves the upper pole, the mode, is it rotatory or is it horizontal? So in this case, just imagine we're doing a disopite, and we move the head down, and we're looking at the eye of the patient. So we move the head like down like that. The patient lying on his right ear there. The right ear is near the ground. So we observe the upper pole of his eye. Is it, if it's contortional nystagmus like this, rotatory nystagmus like this, go towards the ground, this is posterior canalithiasis BPPV. And of course, D is there's no other disorder to suggest other disorder that contribute to the same nystagmus, especially in the case of central cause or the neuritis, in the case of neuritis or labyrinthitis. And the second one is a BPPV, horizontal BPPV, canalolithiasis. The same finding, recurrent attack of induced by head movement, duration is less than 1 minute, and there'll be latency or no latency. And again, this here is as compared to the first one is posterior, where we can see the rotatory. In the horizontal, we see is a horizontal nystagmus. And now, remember when we do the side lying or the hoppite, both we can see the horizontal. And when we see the nystagmus, where is the fast component? Is it a fast component of nystagmus towards the ground? Remember we do we did this hoppite on the right ear of the patient, and we see the nystagmus pointing to the ground. It's a geotrophic nystagmus. Then this is geotrophic lateral nystagmus, horizontal geotrophic horizontal or lateral BPPV is suggests a canalithiasis. And okay, so the third one is a cupulolithiasis, horizontal BPPV. Remember the second one is a horizontal geotrophic, which is canalithiasis. In this case, we can see the nystagmus is horizontal nystagmus, but again, we are doing the hoppite or side laying of on the patient's right ear, meaning the right ear is near the ground. Then we can see the nystagmus, instead of towards the ground, it's away from ground. The first component is away from ground. You can see the eye. So this is a apogeotrophic or ageotrophic. They're away from ground, and usually it lasts more than 1 minute. And this is just a cupulolithiasis. Cupulolithiasis of lateral BPPV. Horizontal, sometimes we call we use interchangeably horizontal BPPV or lateral BPPV. So horizontal BPPV have two, geotrophy and ageotrophy. Geotrophy is going to the ground, is a canalithiasis, meaning that the otolith in the canal easier. And the second one is an ageotrophy away from the ground, is meaning it's cupulolithiasis, otolith stuck on the cupula or the lateral semicircular canal, and it's not as easy as the geotrophic BPV in terms of management. The third one is when we have a patient, and from the history with the suggests of BPPV, or they have all the characters that suggest BPPV, when we do the hoppite, there's no nystagmus. Here in our clinic, we take it if patient have nystagmus, it's a bonus, because we can be sure which canal involved. But if they don't have nystagmus, we ask whenever they increase in terms of floating sensation, increase in terms of spinning sensation. If they say yes, that's we consider positive, and we call it probable nystagmus. Probable BPPV. Then we proceed with, most of the time we proceed with at least, because most common BPPV is a posterior. And when we proceed with BPPV patient, the intensity or the feeling of this floating sensation go away, meaning that we are doing the right thing. It's by deduction. The last one is canalithiasis. Canalithiasis of anterior BPPV. Remember the same finding. There's a provoked by movement of the head. Duration is less than 1 minute. But we now remember the first one when we see the rotatory nystagmus. When we do the hoppite on the patient right ear, the rotatory is towards the ground. Now the rotatory nystagmus is away from the ground. And this is anterior. This is anterior BPPV. Now, let's go to the algorithm of BPPV. Meaning that how we handle patient, how we manage the patient with BPPV. So again, the history and office examination. From the history itself, when we listen, okay, the history is important. The history is important. From our experience, most of the patient with BPPV is diagnosed by history alone. I would say up to 80% from the history alone. History of, just like I mentioned before, with coming up from patient have come out from the sleep, and patient have turned to the left or doing the gardening, everything that suggests a BPPV. And when we do then later on, there are a few things to do. There are a few levels here, but most what I want to highlight here is to examine the nystagmus, presence of nystagmus, and to do this hot pipe. In our clinic, if we are ENT, we are otologists, we are looking at the patient with BPPV, patient with a complaint of vertigo, we need to do this hot pipe, because the hot pipe can tell us whether the patient has BPPV or not. First, we go to the nystagmus first. From the history, and to the office examination, we have to do at least the nystagmus. How? There are two types of nystagmus. One is a static or dynamic, or one is what we call static, is a spontaneous nystagmus. The other one is a non-static, non-spontaneous, meaning that we ask patients to sit in front of us and have a look at their eye, and in a normal position, look at the patient's eye. This is, if the patient having straight away there's a nystagmus there, it's a spontaneous nystagmus. Or when there's a non-nystagmus on the patient looking at us, and we do this test, and there will be a nystagmus, gets evoked nystagmus, there's a spontaneous nystagmus over there. Then we grade there. That's a different issue. That's not BPPV. That can be a central cause, and it can be labyrinthitis or neuritis. Okay, so what we're more interested today in this morning is when there's no nystagmus there, but from the history it's like BPPV, and we check this mean, please ask patient to do that. Then there's no nystagmus, then we need to induce the nystagmus by doing the dissolved pipe or side laying procedure. Usually in the clinic we do dissolved pipe easier. So when we do the dissolved pipe, remember the one that I mentioned before, we hold the head and turn and do the patient do the right the hot pipe to the patient, meaning the right ear is near the ground, and we look at the eye of the patient, especially the upper pole or upper limbus of the patient's eye. First, try to look for any nystagmus. If there's no nystagmus, we go back to we ask patient whether there's increased sense of floating, sense of sensation or not. If there's no nystagmus, but there's an increase in sense of floating, sense of spinning, we consider it as positive as well. We wait for at least 30 seconds, because remember the otolith that takes some time to drop, and then there'll be latency. So if there's a nystagmus, we look for the type of, we notice the type of nystagmus. Is it rotatory or is it horizontal? So you can see here. First, if it's a rotatory, while looking at the patient's eye, see the direction of the nystagmus. Is it towards the ground or away from the ground? Remember, this is the position of the head of the patient when we do the right eye place. Patient right ear is near the ground, it's towards near the ground. See, we see the upper limbus. We see whether the nystagmus direction is rotatory. In this case, rotatory is going toward the ground. Not it's towards the ground. It's a posterior BPPV. And sometimes we see it's away from the ground. It's instead of here like this, it's away from the ground. That's anterior BPPV. And if you notice is when we done this posterior BPPV, the maneuver involved is Eplis or Simon. And the other, of course, there are other tests maneuver as well as GANs. We have Gapiani, Kofoni, but here in our clinic, we are more comfortable with Eplis and Simon. And if there's a upbeating, meaning going the rotatory nystagmus is away from the ground, is the anterior BPPV. And we usually will proceed with the dead head hanging, or straight head hanging, or reverse Eplis, meaning that if patient have right anterior BPPV, we do left Eplis, or we can do diastasis. Sometimes there's no nystagmus, but patient complain when we come up from the hoppite position to the sitting position. The patient complain of a spinning or floating sensation for more than 5 seconds. We take it as a positive and we proceed with the maneuver. And most of the time, it's a go away. So we, by deduction, that's our diagnosis. Now, first we see the nystagmus and the type of nystagmus. Then second, we see the, is it down, is it going to the ground, away from the ground, or towards the ground? Same. And the third, the second is a horizontal nystagmus. Instead of rotatory, it's horizontal like that. Again, it's important for us to see where the nystagmus goes, where the direction nystagmus. Again, the same condition, the same position, right? This hoppite, we look at the direction nystagmus. Is towards the ground, is a geotrophic. As a geotrophic, it's canalithiasis, but it's like this. If away from the ground, it's a ageotrophic, apogeotrophic. Is away, it's a cupulolithiasis. So if you can see from this algorithm, if horizontal, we do write this hoppite in this patient, and we see the horizontal nystagmus, and the direction is towards the ground, is a canalithiasis. Remember, the canalithiasis is the otolith is in the canal, which is easy, relatively easy to manage. So we proceed with log row. If you have big space in your clinic, you can do log row and patient row on the ground, on the floor. But most of us don't have that luxury. We do the barbecue. Patient on the couch, and we move the head to 360 every 90 degrees, just like a barbecue. Okay, then most of the time patient respond. It's not much a problem. The problem with ageotrophic, when you see the nystagmus, instead of going to the ground, it's away from the ground. And we know straight away this is a cupulolithiasis, meaning that the otolith stuck on the cupula. And we need to get the otolith to become canalithiasis first before we can proceed with log row. Because at this moment, from our experience, is log row alone without log row in the cupulolithiasis alone won't. It doesn't really happen. It doesn't really help. The patient doesn't respond that well. So in this case, in the case of ageotrophy, we need to make it canalithiasis by doing this Goffoni maneuver. Don't worry about the name. It's a simple maneuver, but done by this guy from Italian, from this Goffoni. So we do Goffoni until there's become geotrophic horizontal nystagmus, and then we do then we do the log row and BPPV. So many, in the case of ageotrophic horizontal BPPV, there are two maneuvers involved. One is a Goffoni, and the other one is a log row. So now, remember when we say there's sometimes there's no nystagmus. So we take it from the history to suggest which type of BPPV involved. Posterior BPPV without nystagmus is quite easy to diagnose. Patient complain of classical textbook presentation. Wake up in the morning, bending down, turning to the left, and from the history, then when we do the test, we do the hoppite, there's no nystagmus, but patient complain of increased sensation of spinning, increase of floating. Then we do the posterior BPPV, the police or summon, is go away. So we diagnose as a probable posterior BPPV, respond or resolve with a police. Same as an anterior BPPV here. Anterior BPPV, okay, again, anterior BPPV, just like I remember, I put that textbook fact about BPPV is rare. But here in our setup, in our clinic, anterior is more common as compared to lateral. And it's a good thing about anterior, it's easier to manage as compared to lateral. So we have here in our clinic, first is posterior, followed by anterior, and last is anterior. Last is the lateral. And lateral geotrophy is more common as compared to ageotrophy, which is good. because atrophy is most problematic to manage. So how we diagnose? I think we think anterior BPPV is underdiagnosed. So how we diagnose it? From the history itself. From the history itself. Sometimes patient give a history of not spinning but rolling. Just imagine patient is driving, then suddenly they have the feeling of rolling in front. That's very dangerous. And patient feeling like that. And patient say, I couldn't sleep I couldn't sleep lying down. I need to sleep on one side or this side. I cannot sleep lying down like that. So every time I wake up in the morning, I need to hold to my bed first, and then even during the procedure itself, when we do the hop pipe to the left, right, the hop pipe, left, the hop pipe, patient don't really have a problem. But once patient sitting up from that position, from the hop pipe position, patient complain that, then we take as 5 seconds as a cut-off point, because some of us, especially are more than 50 years old, more 55 years old, we have some degree of a giddiness or near fainting spell, or just a bit uncomfortable when we wake up. So 5 seconds is more than enough. So if patient have increased feeling of giddiness, spinning sensation, getting up from the lying position in our clinic, 4 or 5 seconds, we take it as a suggestive of anterior. Then we proceed with the head hanging or straight head hanging, and usually patient the symptom go away. So by reduction, that's anterior BPPV. Now, for geotrophic, for lateral horizontal BPPV, from the history alone, when listen to history, patient say, doctor, this is I have a severe vertigo or severe sensation and followed by vomiting and nausea feeling. It's very bad. I couldn't really wake up the whole morning. That careful. That suggests of lateral. Because from our experience, anterior and posterior rarely cause severe sensation, or patient rarely presented with vomiting or nausea feeling. Nausea is there, but vomiting, rarely. It's our experience. But those who have lateral, they will come almost always come with the history of vomiting. So when patient listen to some patient have that vomiting, severe, and the presentation itself, the severity of nystagmus, the severity of the symptom itself suggests of lateral BPPV. Okay, let's talk about issues in BPPV. When we see the BPPV, there are things that we couldn't explain, or the thing that we think that we should be aware of. And there are a few issues here, and we go one by one. We go over this slowly. First, the diagnosis. As I mentioned before, nystagmus is not always present, and this is due to composition. So it's interesting when we start our clinic early in our career, and we see patient, we have other clinic first in the morning. We see the vertigo patient in the afternoon, and most of the time there's no nystagmus, and it's happened because this compensation happened, and patient have just give a feeling of floating sensation that usually there's no nystagmus. So we see patient early in the morning, meaning we have we see patient in the morning, and then we see a lot of patient nystagmus. And if there's no nystagmus, again, just like that when we discussed before in our discussion, we ask for the increased intensity of sensation, floating sensation or spinning sensation, and we take it as a positive. That's our diagnosis as well. And of course, as we put as probable posterior or probable anterior BPPV. Again, this is the one that I'm discussed before. Before it's a posterior BPPV most common, so we suspect this one first before the lateral. And again, lateral, if especially when from the history, it's not as severe as from the history. It's not as that severe. Then mostly it's a posterior. And then the other one is anterior. The anterior. then we have to wake. We have to listen, and if there's thing that that suggests the anterior, we do straight away and we do the head hanging. It's no harm. Benefit of the doubt, we proceed with the head hanging, and then hopefully we can help patient. And to share that again, to keep in mind what from our experience, anterior is more common, definitely more common than lateral. So we dare not to say this because it's against the textbook fact, but this is our experience. The last one is a central cause that mimic peripheral vestibular disorder. And again, sometimes we are too thinking of the peripheral, we miss the central cause. The two common central cause that mimic, meaning that the presentation is like a peripheral vestibular disorder, is a multi-lacunar infarct or multifocal lacunar infarct and brainstem stroke. So, and we have a patient, middle age, smoking, with high risk, everything, and we have presenting with a kind of like a BPPV but doesn't really respond with our treatment. Please check for the other cause, which is again sometimes I do ask for a CT scan just to be sure this is not stroke or infarct there. Diagnosis is not a single diagnosis. Sometimes they come with multiple problems, which is what I mean is not premorbid. They have diabetes, hypertension, yes, but the diagnosis of vertigo itself is not a single diagnosis. It can be multiple causes that lead to the same presentation with diagnosis. And sometimes we have otolite issue, meaning otolite issue, what I mean is a BPPV, anterior, posterior, and lateral. Sometimes they have this otolite issue plus neuritis, or plus labyrinthitis, or plus with a Meniere's. And presentation is a bit jumbled up, and sometimes we are not sure. We a bit confused, but we need to lay down and tackle one by one. And sometimes they have this issue. They have otolite plus neuritis, or otolite plus neuritis plus Meniere's. That's good. And plus sometimes we have peripheral vestibular disorder with central, especially in those who are more than middle age. Remember, BPP more common in those age, more than 55 years old. And at the same time, they are more prone to have central problem. They have a stroke, they have multiple lacunar infarct, plus at the same time, they have a peripheral vestibular disorder. So careful not to miss other diagnosis in this case. Multiplanars BPPV. Remember, we have 3 plane here, 3 plane here, we have 6. And sometimes they can have in the single ear, we have 2 planes, 2 planar that involve. We have anterior BPP plus posterior BPP, or we have 3 posterior, lateral, and anterior on the single ear. Or sometimes we are not very lucky, we have 6 planars. So in this case, patient, when we do the hop pipe, patient giddy, And worst scenario, there's no nystagmus, and when we do the hop pipe, is patient giddy in all direction. That's a multiplanar things. And sometimes when patient have a right sensation over there, then we do the right at least, because we thought this is posterior. And suddenly when that right ear spinning lesser, patient component on the left side is more now. So that kind of thing. So and plus another point that which is important point which I would like to share, that when we do this hop pipe and we see the nystagmus, say we see the rotatory downbeating, the rotatory nystagmus toward the ground, and wait until it go away. Sometimes we got intensity there, yes, and then decrease center or intensity, and towards the end you can see it's changing direction. First they become like this, towards the end it's changing direction. This is not central. This is multiplanar, meaning as saying first they have posterior, but at the same time they have anterior BPPV. And patients usually complain to us the worst planar that involves, say the posterior is is worse as compared to anterior. So they complain of lying on the right side, on the left side is worse as compared to sit down coming up. So we settle that one first. The worst presentation first before we settle the other things. So multiplanar do occur, and we need to tackle, see what the worst presentation first, the worst complaint first. We tackle one by one. Now, the other issues are recurrent and recalcitrant. Recurrent, we do the BPPV, then next week it come again. This week we have, say the patient have posterior BPPV. We managed to do we need to put back the otolith. And next week they come again. Then after awana they come again. So this is recurrent. So, and just like I say, it's 50% patient will have recurrent. And of course, some paper say if you do GANs, you do SMON as compared to this is better. Up to you. I mean, I'm waiting for the meta-analysis or systemic review for that things, which to say which what I call that maneuver is better in terms of to reduce the maneuvers. So at this moment we still stick to the APLIS and SMON because it's easier to do, it's less stress to operator and less stress to the patient, and less of not that we are not shaking the head too much. And yeah, same. Recalcitrant is meaning that after doing 4 times the maneuver, one sitting where we do 4 times, the problem doesn't go away. First, maybe our diagnosis, but sometimes we see the nystagmus we are very sure there. Second is simply stubborn, recalcitrant BPPV there. And what we do here is just after some time we stop, we give sedative, we give a vestibular suppressant. In our clinic, basically it's a stenarizine, it's a lesser suppressant as compared to stamethyl or Phenergan, is Phenergan or stenarizine there. And then we ask them to come back 2 days time or 1 week's time to do, or usually after 2 days time to do again the maneuver. Recurrent and recalcitrant, recurrent basically, and recalcitrant maybe got to do with this bone demineralization that may be involved. Remember that the bone density score show less in patient with recurrent BPPV, and there's a study there suggesting we're using of vitamin D and calcium supplement in this kind of patient. Vitamin D. So in our clinic, we do use calcitriol. That's the easiest thing to get hold of, and one tablet per daily. And we do not see much difference that yet. We don't have the big study to confirm, but we rely on the other study that say there's some significant improvement given with vitamin D and calcium supplement in case of recurrent BPPV, not in recalcitrant. Types of BPPV. This is already discussed. Just to highlight again, and we've been taught there are 3 types: anterior, posterior, and lateral. But actually, lateral have 2. Why is got to altogether 4? At least 4 types of BPPV. Why? Because these all 4 types of BPPV we need to tackle with different maneuvers, meaning that we cannot use everything in all maneuvers. Before some of us think that we can use APLIS or no. APLIS is the best for posterior. Anterior is different maneuver. Lateral geotrophic, which is canalithiasis, different maneuver. And lateral ageotrophic or cupulolithiasis is different maneuver. So these are 4 maneuvers. So just to share our mistake before, then to share everybody to bear in mind it's different type of BPPV, different ways to tackle it. Drop attack. When we say drop attack in otology, it means Tomakin attack or autolytic crisis. I don't mean that. It's not menias. This is not about menias. but I don't know. I couldn't find any better word term to put here. So what happened now? We have a patient who have confirmed to have BPPV, and we do a maneuver successfully take out the otolith in the canal, and the otolith go to the vestibule. And some of the patient coming up sitting on the couch, suddenly they stutter. They have a brief history of loss of balance there. So careful, ask the nurse or ourselves to hold the patient, not to release them immediately. Hold them for a few seconds or 10 seconds at least. See, it do happen. And another group of patients, they're quite okay when we do this maneuver, and this quite okay, and we think they release everything. We resolve the problem, and they go back. At home, they have a severe attack for 1 day. They're at home, they say, doctor, it's a very severe. I couldn't wake up from my bed. I had to crawl to the bath. I had to take my food on the bed. And finally, it's occurred only 24 hours, only 1 day. And so there are two now: dry attack and this severe attack at home post maneuver, post successful maneuver. I couldn't really explain why, and couldn't really give any good explanation on that. Actually, there's nothing in the literature on that. So my assumption, that's what happened. Why the patient having this? Because I think I might be wrong. When we do the maneuver, the otolith, the multiple otolith in the canal, they come together and they stick to it to become one big clump there. And suddenly when they move slowly, when patient sitting up, they drop. Then can cause that dry attack. Or they break up in pieces, and they keep on releasing these pieces, and that's why there's a problem. And remember your canal there, then they roll, and near at the opening, they cannot come out. Everything cannot come out to the vestibule. They break out slowly, and they keep on releasing for a few hours, and that's why maybe that's the reason why at home they still having this problem. That's my assumption. Doesn't mean it's right. Association. This is what we found out. BPPV is highly associated with migraine, either basilar or vertiginous migraine. So it's good for us to ask patients whether they have the symptom of migraine, and if they have, please treat the migraine. Because if patient have background migraine and patient have BPPV, they escalate or they aggravate the symptom itself. So pity them. And how we, meaning that we treat the best migraine. So sometimes it's the easiest thing to ask them, patient with BPPV, when we suspect, and to suspect whether they have migraine or not. Ask them whether they can read in a moving car. So if last time we read book, now no more people don't read book or newspaper in moving car. People read WhatsApp, also WhatsApp. So whether the person can read the WhatsApp on their phone. And those who have hypersensitive to motion or motion sickness, usually they have a background of migraine, either basilar or vertiginous migraine. And do ask them for this. Last is acute vestibular syndrome, and this is we think in our clinic is important to highlight. Why? Most of us are lucky because we have very competent, very good colleague in the imaging department. Most of the acute vestibular attack is seen by them. And however, some of us have some idea that when patient have sudden onset of spinning sensation, vertigo, and worse with head movement, this is BPPV, otherwise. It's not always so. And in this case, in acute vestibular syndrome, patient have sudden onset, but the vertigo, spinning sensation, spinning is longer, lasts more than a few hours, and worsen with the head movement. Most of the time, it can 50% of the time, it's a labyrinthitis or is a neuritis, but 50% is a acute stroke, posterior circulation. So bear in mind. So do not miss the stroke part. But that's why I say we are lucky, because this kind of thing, this kind of symptom of acute vestibular attack syndrome is seen by our ED first. What they did the CT scan, everything, only then they refer to us, which is good. So do keep in mind the acute vestibular syndrome. We need to rule out stroke, not to stick to BPPV. Yes, BPPV, but we need to rule out, is it stroke or not? Okay. I think that's the last slide. Thank you. And this is my reference on the consensus from the Bahrain Society. Okay.